The American College of Cardiology and MedAxiom are transforming cardiovascular care together. Welcome to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom Heart Talk starts now.
We are so pleased to have with us today Dr. Christopher Ott. He is the Chief Medical Officer at HCA Physician Services Group, and he spoke today about captive payer populations. I so enjoyed your presentation, and I was intrigued with your opening when you said you don't like the phrases population health and volume to value, because that's something we seem to hear so much of. Why don't you like those terms?
So to me, those two terms are just catchphrases, and they don't actually explain what the problem is, right? Population health to the general population and to some policymakers is taking care of everybody in a given catchment area, and that doesn't make sense for private industry. That doesn't make sense for non-public healthcare providers. And so we use captive payer populations to describe what other people would call population health, which is a known group of patients aggregated because of a particular payer, Medicare, Medicaid, commercial payer, maybe an employer program, and how we deal then with that given population, not the population as a whole. Okay.
And you have HCA is the largest healthcare provider in the United States?
That's correct.
So you've been working at this for a few years, I think you said.
Correct.
And what have you learned in that time? What are some of the, after 5 years
Yep.
or so of experience,
Yes.
what are some of the big takeaways about how to succeed in the reimbursement arena and with the captive payer population?
So I think a couple things that we do well that you have to do well in this. You have to have access to your data. You have to know who the lives are that you're caring for so that you're looking at the appropriate data. And then you have to be able to act on whatever that data is that you've aggregated. So you have to have an electronic health record, you have to have a data warehouse to study the data, and then you have to make sure that whatever infrastructure you build to act on that data doesn't how do I want to put this? That you don't overbuild your infrastructure to respond to the needs of that population.
What does that mean?
So to me, that means there have been a lot of large systems that have gone in and hired a ton of care coordinators, a ton of educators, and a ton of FTE or IT infrastructure, and they haven't moved the quality needle. They haven't decreased their spend per beneficiary, and they're not in arrangements where if they moved either of those, they get to share on those savings. They got in too quick, they built too much infrastructure, and they wasted resources.
Okay. So what do you recommend is then some of the first steps that you should do to avoid that?
So to avoid the overbuilding of infrastructure is to basically understand your population and what the problem
and the data
and the data that you have. So if you have an over-hospitalization problem, if you have an overutilization of post-acute care, if you have overutilization of non-generic drugs or home health care, all that you should be able to see that in your analytics, and then you go after each of those individual problems. You're not going to have huge buckets of problems with every population, and so make sure that you tailor whatever program it is, because if your problem is post-acute care and you're running after emergency department utilization, you focused on the wrong thing. You built infrastructure to solve a problem that is a generic problem, not a problem for that population, potentially.
Okay. For cardiology, more specifically, what should cardiology practices on cardiovascular groups be focusing on?
So in populations, and this is not unique to cardiologists, it is all specialists, but cardiologists, because they make up such a large portion of spend for the Medicare population, they need to do a couple things. They need to have access to appointments. So if I'm a primary care doc in one of these models, in a captive payer population model, my patients need to be able to get in to see you, and they can't be 6, 8, 12 weeks out. They need quick access. You have to close the referral loop. After you see my patient in a timely manner, I need to know what you did to that patient, what I need to do next, and that the problem was potentially addressed or is being addressed. And then the third thing is I need you to document it. I need you to tell me not only what you did, but you need to tell the health record what you did. And you need to bill appropriately, because then you're telling the payer. And it's the health record and the payer data that turns into the data that allows me to actualize the performance of whatever I have set up, a clinically integrated network, an MA, an MS, Medicare Shared Savings Program. So the cardiologist and the specialist data being fed into this appropriately, referral loop closure, just kind of juices the system. It helps along the way so that then I'm able to better respond to those populations.
And currently, does that not happen as it should or as often as it should? Is that a big issue right now?
Yeah, I mean, I think cardiology access is limited. And so, yes, there are access issues. I think the variability in IT systems, so interoperability, if you're on Athena and I'm on ECW and the GI guy's on Epic, we have a problem. I need to figure out how to get records in and out of those systems. And so figuring out how your system is going to talk to mine, huge. Figuring out which system we're both going to use for referrals, big deal. And then figuring out how I'm going to get patients to see you and you're going to treat them in a manner that is expeditious and cost-effective is something for you to figure out.
Right. Okay. One of the comments you made toward the end of your presentation was recommendations is to avoid getting lost in the alphabet soup. How do you recommend that they do that?
Yeah, so part of the talk, there are ACOs, CINs, Medicare Shared, MSSPs, MA Medicare Advantage, there's MSOs, IPAs, right? There are all sorts of ways to aggregate patient populations and providers into provider alignment organizations. When I tell people not to get lost in all that, because there's variation in how each of those run and how dollars flow through them, they all need you to do the same thing. They need you to provide the same quality of care. So you can't spend less and provide lower quality care and win. Right. The first hurdle is quality is held harmless. So you provide quality care. That's easy to remember. Make sure that if you got your flu shot last year, you get it this year. Make sure that your diabetes was managed last year, it's managed this year. The second component of controlling that population or those costs for the cardiologist and for any specialist is, again, when you do those things, communicate them back.
Document.
So you did, you document, you communicate, repeat. There's not a lot there. You can get more specific into your particular utilization. So if one of these platforms come to you and tells you you're in the top decile of ultrasound use, of echo use, or you use 80% more generics or 20% more brand than your peers do, that's something you have to address then, because you will be an outlier in cost. Right. And that's kind of first quality, then communication, then manage cost.
Right. Okay. Well, thank you so much. I really appreciate your time, and we are so glad that you were here with us today.
Thanks for having me.
Okay.
You've been listening to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together to transform cardiovascular care for all. You can follow MedAxiom, an ACC company, on LinkedIn, Twitter, Facebook, and YouTube. If you haven't yet, please subscribe, rate, and review this podcast. Join us next week for another MedAxiom Heart Talk episode, and thanks for listening.